Hello, 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 and thank you for joining us again this evening. If you're just joining us, you are watching Essential Conversations for Improving Vaccine Uptake in Black Americans. And so this is in conjunction with the National Black Nurses Association, as well as the National Medical Association. And we for the past two nights, so last night we had a presentation by Dr. Brown about vaccines in children. And so she was a pediatrician and she did a wonderful job kind of explaining the whole vaccine process. So I encourage you, if you didn't watch last night's program, I encourage you to go and watch that. It was very, very informative and really kind of gave some different perspectives with regards to where we are and how we got to this point with the vaccine. So we're not in a silo. We're seeing that all vaccines are connected in some way. And so she did a great job explaining that and why it's important to vaccinate our children. Tonight, it's all about you and the adults. And so we're going to be talking about, so we've got a wonderful, wonderful speaker tonight, presenter tonight, this Dr. Virginia Caine, and she's going to be really helping us adults, grown folks, learn and get to know what we need to know. I know it's been almost 3 years of this pandemic, but Dr. Caine is really going to break down where we are, where we're coming from and where we're going with regards to this vaccine. And so I've had a little sneak peek of her presentation and you do not want to miss this. So this is wonderful. So let me explain to you who we have joining us tonight. So we have Dr. Virginia Caine. She is a director and chief medical officer of the Marion County Public Health Department. She is an associate professor of medicine at Indiana University School of Medicine, Infectious Diseases Division. And she also chairs the National Medical Association Infectious Diseases Section and is a member of the NMA and the National Links Incorporated COVID-19 Task Forces. And so just to kind of give you a little bit of background about where she is and who she is, but let's bring her on so you can meet her yourself. So welcome to the program, Dr. Caine. How are you?
Well, hey, Ellis, I'm appreciative. I see that you got promoted and you've become an adult now from your juvenile days. That's incredible.
There might be some people watching me from my juvenile days, and they would beg to differ. I might still need to get the baby dose of the vaccine.
Well, first, let me just say, I just want to thank our national president, Doris Martha Dawson, and also my ACE cum colleague, president and CEO of the National Black Nurses Association, Melissa Gorsham. And so for just giving me this opportunity and invitation to talk about one of my favorite subjects, what's happening on the latest front for COVID-19, especially in adults, as it relates to vaccines and other issues.
Well, we know the seriousness, right? We know we just crossed over the 900,000 death mark here in the United States. We know that it's still going on, even though we all have COVID fatigue and decision fatigue and mask fatigue and all this other fatigue, but it's still going and people are still being hospitalized. They're still dying, even though it might be at a lower rate, it's still happening. And so we've got to do what we can to end this pandemic. And so hopefully some people will learn that from your presentation tonight, get the information they need to make that vaccine decision so we can get to herd immunity.
Well, hey, thanks for the opportunity.
Absolutely. So let's bring up your presentation.
All right. I'll take the next slide and just say that I have no disclosures. Okay. So listen, we've had more than 911,000 people died in this country, and we've had more than 77 million cases that have been reported in the United States. And worldwide, we know we've got way more than 5 million in some cases that are occurring. Next slide. Next slide. But let's just say what's been happening in the past week from January the 14th, where we were experiencing 800,000 cases per day. Those cases have dropped about 43%. We're experiencing a little bit over 200,000 cases of COVID occurring as of yesterday in the country. But our death rates are still sort of slightly declining by only 3%. So we're still having about 2.5 thousand individuals dying from COVID every day. And I have dramatically seen now, with all of the robust cases that we had as a result of this Omicron, that our hospitalizations are finally falling. And so instead of admitting like over 150,000 cases in this country a day, we have now dropped to almost just 100,000 cases. And so that has dropped by about 20%. Next slide. But this just gives you a flavor looking at the hot spots of reported cases that are occurring per 100,000 residents. And one of those little circles, the larger they are, that means there are about 3,000 reported cases almost per 100,000. And so if you can look at your states, you can see Canada, Louisiana, Mississippi, Tennessee, Virginia, West Virginia. You can see that really thick cluster of lots of cases occurring there. And if we looked at this map, we appear to have more cases in the Midwest, the South, and Northeast compared to our Western states. Next slide. But how does this impact people of color, especially African Americans? What is our risk for this COVID-19 infection? So if you looked at the Black category, which is the third on this table, we roughly have almost the same number of cases compared to our white counterparts. And don't forget, when we're having almost 1 times the number of cases with our white counterparts, we only make up 13% of the whole total United States population. So if we're matching almost case per case with our white counterparts, that tells you how incredibly we're being disproportionately impacted. But here's the crux of the matter. We are at 2.5 times the hospitalization rates compared to our white counterparts. 2.5 times. And we have nearly twice the death rates compared to our white counterparts. In Hispanic or Latino persons have similar data. In our Native American Indians or Alaska Natives, they have the highest number of cases, the highest hospitalizations at 3.2 times the rates of their white patients, and they have a little bit higher death rate compared to African Americans. Next slide. But what does this mean? It means when you're looking at us in the hospital setting, we are predominantly over 50% of those cases appear to be mostly Blacks, African Americans compared to the other different racial and ethnic populations. Now, what are the symptoms should you look for? Symptoms usually appear 2 to 14 days after exposure to the virus, and you may experience fever or chills, cough, shortness of breath or difficulty breathing. You used to have no problems walking 2 or 3 blocks. Now it's a chore just to walk 1 block because of shortness of breath. You've got significant fatigue. Muscles of your body's aching. You may have a headache. And if you get a new loss of taste or smell, know that that is COVID-19 until proven otherwise. A new loss of taste or smell. And that loss of smell is such that you can't smell smoke. So you can have a fire going on in your home or your apartment, and you won't be able to smell it. And these can last weeks to months. We also see sore throat, and we've seen more sore throat symptoms in this new variant, the Omicron variant, compared to the other variants that we've seen in the past. But it can just look like a common cold with congestion or runny nose. We do see a lot of GI symptoms, though this seems to be a little bit higher in children and teenagers, but you can experience nausea or vomiting or diarrhea before you develop the symptoms of COVID-19. And the seriousness of the COVID-19 is related to the fact that in a lot of these patients, they develop pneumonia. Next slide. But When should you seek emergency medical care? So if you're having an issue of breathing, or you may complain of persistent pain or pressure in your chest, COVID has been associated with almost every organ of the body. So you could be having a myocarditis, inflammation of the heart, a new confusion, it impacts the brain, or you may be lethargic, an inability to wake or stay awake, and bluish lips are on your lips or face. When you have these symptoms, don't just say, hey, I'm going to lie down for just an hour or two, and then if I'm not feeling better, then I'll go and seek emergency care. No, chances are you may not even wake up. So when you're having these emergency symptoms that I'm talking about, you call your medical provider, or you get into an urgent care or emergency room if you're experiencing a number of these symptoms and they are lasting longer than 15 to 20 minutes, and you don't have any underlying condition that's usually associated with this. Consider this an emergency warning for COVID-19. Next slide. So just to say, hey, nurses, you guys are on the forefront. The first nation to nationally give a vaccine out of New York, and the first national recipient of taking the vaccine was a nurse. You know, you got all the power. What can I say? Next slide. But I do want to always acknowledge Dr. Kizzmekia Corbett, who at the NIH was the leading researcher for developing one of the major COVID-19 vaccines, Moderna, along with a Massachusetts biotechnology company, to say that it is a Black female who is the lead researcher at the prestigious National Institute of Health. And the girl is young now. She is young. And so when she's young and that bad, now you know the girl is smart, intelligent. And the most important thing is she wants to bring back to her community all the talents and all the resources that she can in order to help all of us in our community. So kudos to Dr. Corbett, who's now in the faculty at the Harvard School of Public Health, and may she continue to do wonderful things in terms of saving our nation. Next slide. So how do these new messenger RNA vaccines work? So if you see on this slide, there are proteins on the outside of a cell of the virus. And one of these proteins is called a spike protein, S protein. It's that particular protein that allows that virus to attach to a human cell and penetrate and get into our human cell and replicate in large numbers. Next slide. And how does this work? Well, if we inject the vaccine, and this is a man-made vaccine, you know, most of our immunizations used to have to do with live vaccines. This is not a live vaccine, but it does contain a messenger RNA that with this vaccine, and it goes to our human cells and says, make these spike proteins. Now, your immune system says, wow, I don't recognize these proteins. And so my body starts producing antibodies. It starts attacking them. But it takes about 2 weeks to build up sufficient antibodies. And so, but after that happens from the vaccine, when we finally get an actual coronavirus presents itself to our system, our immune system can now use those antibodies that we produce as a result of the vaccine to attack those spike proteins. And they can attach to those spike proteins, block it, so that these viruses can now not find any way to enter our human cells. Next slide. So let me tell you the true myths. There's no live virus used in the vaccines. It's only a copy of a virus protein, a component of a virus, a protein. It cannot cause COVID whatsoever. And when we get these vaccines, the side effects, our body's experiencing an immune response. We're in a battle here. So as a result of our immune response fighting against this infection, we can get an achiness, we can get fever and fatigue. And I want to remind everybody that COVID can impact every organ of the body and frequently attacks our respiratory area, cardiac, neurological issues, which sometimes result in deaths. And there is no way that this virus can alter any of our DNA, because the messenger RNA only enters the cytoplasm of a cell, and it can never alter any of our DNA because our DNA is located in the nucleus or very center of our human cells. Next slide. So, hey, see these zombies? That's that COVID-19 virus. And it's continuing to mutate and continuing to change. We started out with the Alpha variant virus of COVID-19. Eventually, we have moved through the Delta variant, which occurred this past summer of August, in August 2020. And now we've moved to the newest variant called the Omicron, which is B21. And even it has a subvariant now called BT2, called the Steph variant. So, and we don't have any idea whether this one is going to be as contagious as the Omicron virus, but we think it may be more contagious than the current Omicron virus. But next slide. Our vaccines, next slide. Oh, sorry, go back. I guess it didn't work. It's supposed to zap. It was supposed to zap a virus, but that's okay. All right, we'll keep going. Now, why should we get vaccinated? Why is it important that people consider being vaccinated versus, I'll just take my chances. I never get sick, so I'm not worried about this. Well, we're worried about the long haulers, the long-term effects related to getting an actual COVID-19 infection. And somewhere between 18 to 30% of people will get these long-term effects from having COVID-19, and they will complain of chronic fatigue syndrome. This is where you're exhausted and you're so tired. I mean, it's a chore to go from your bedroom to your bathroom to use your bathroom. And you don't have a lot of good moments. I'm a number of hours in the day, I feel good. No, this chronic fatigue is constant. And it has caused almost 80% of the people who have had chronic fatigue syndrome have not been able to return to work because they're so exhausted and they can't carry out their normal job duties. People can develop shortness of breath where they didn't have it before, a persistent cough. A lot of times people say, whoa, I'm developing arthritis now because all my joints are continuing to ache all the time. I may experience chest pain because of inflammation of the heart. But we also see, because it has a vascular component to it, that people are at high risk from clotting of having strokes, seizures, and we've even seen Guillain-Barré syndrome, a condition that can cause a temporary paralysis where you're unable to walk or anything. And listen, some people, they because of their speech, they can't talk. They may have to have physical therapy in order to learn how to rewalk again, speech therapy in order how to talk again. And there could be the possibility of some lasting damage to the heart, with increased risk for heart failure from COVID-19. Next slide. People can get a chronic headache. We've had patients that have just had severe headaches, but they never had headaches before. They continue to have arrhythmias of their hearts, where it's pounding or rapid heartbeats continually that they see. They can have loss of smell or taste for weeks or months. But the other one that really causes a lot of concern for people is the impact on your memory and your cognitive ability, where you get this brain fog. I hate to say this. You might not remember, who your first significant other is, or who was your roommate in college, or just key people that you should know who they are. Your brain is having difficulty concentrating and having the ability to do cognitive thinking. And some people are left with a sleep disorder, such as insomnia, where they never had any problem before. Some of our patients have experienced rashes occurring on a frequent basis, hair loss. And if you've ever been in an intensive care unit and been on a respirator, a lot of these patients are left with post-traumatic stress syndrome, some experiencing a higher rate of depression, but it's an anxiety and jitteriness as a result of their COVID-19 infection that they have had, that they're left with these long-term symptoms. And they keep telling their providers about this. And initially, at the beginning of this epidemic, a lot of these folks were sort of ignored their symptoms as though that they were not true symptoms. Next slide. So when we look at the COVID-19 vaccines, next slide, I just want to highlight that of the cases that we're seeing in our hospital systems, 90% of the cases are in people who are unvaccinated, okay? So anywhere from 10 to 20% of the hospital cases are the people who are vaccinated. And so when you look at who is flooding our hospital systems, overwhelming our hospital systems, a significant percentage are unvaccinated. Next slide. So we have now, since this epidemic, have fully vaccinated 213 million people. We have a total of 340 million people in the country. And so overall, we're at 64% of the United States is fully vaccinated. If we're looking at all of those individuals who are over the age of 18, 74% of the United States are fully vaccinated. And of course, if you're over 65, nearly 90% are fully vaccinated. Next slide. And if we look at those who are eligible for booster doses and have taken their booster doses, we find that 42, or rounded out to 43% of the people have received their boosters. But if 43 have received their boosters, that means over 50% of the people who are eligible for boosters have not received their boosters yet. And we've got a new terminology now. Instead of saying people are fully vaccinated, we are now talking about, are they up to date with their vaccinations? So if you've had your primary series of vaccines with your Moderna and Pfizer vaccine, these are the Messenger RNA vaccines, and you are eligible for a booster vaccine, but you have not received it, you're not considered up to date with your vaccinations. Only if you get your booster when you're eligible, plus your primary series of vaccines, are you considered up to date. Next slide. how does it break down? How do we look in terms of COVID-19 vaccinations in the United States by race? And although I apologize, I know all these lines are blue. I'll get it together. But the very lowest line with the circles, that is the African American Black population that has received at least one COVID-19 vaccine. And so as of January the 31st, 55% of us had received at least one dose. And we're about 6 or 7% lower than our other racial and ethnic populations, with the highest vaccination rate in our Asian population at 83%, but our second largest vaccination rate are in our Latino X population and our white population, nearly the same at 62 and 61% respectively. Next slide. So how effective are these vaccines? Well, at the start of this epidemic with the Alpha variant, they were nearly 95% effective, okay? But when the Delta variant came along, our efficacy kind of dropped to like just below the 70%. But when you looked at a real life study, the effectiveness at preventing hospitalizations, that means that you developed a more severe complication of the vaccine. Moderna was the most effective at 93%. Pfizer was at 88%, and the Johnson & Johnson was 71% for preventing hospitalizations. But this was primarily related to the Delta variant that occurred at that time in late September. And so what are our risks of getting the COVID-19 shot? Well, most people commonly experience fever, headache, fatigue, pain at the injection site, and these symptoms usually last up to about maybe 18 to 24 hours. Now, serious side effects can occur too, and they are rare, but anaphylactic shock has been associated, and that's why we know people have to go, and once they get their injection, have to remain for 15 minutes, so that if epinephrine is needed in order to counteract this anaphylactic allergic reaction, they're able to do that safely. Next slide. But just recently, in a White House briefing from our CDC director, Dr. Walensky, and the White House COVID-19 response team, people were saying, okay, well, we understand about the Delta variant, but just how effective is our vaccines related to the Omicron? And if we looked at the effectiveness of just having 2 doses of the Messenger RNA vaccines, Pfizer and Moderna, how effective is it against Omicron? And how effective is it against the Delta variant? So this slide shows when you're against ER and urgent care visits, that 6 months after taking the second dose of either of the vaccines, our vaccines of Moderna and Pfizer was 86% protective against the Delta variant, but it was only 52% effective against the Omicron. And if you went out as far as 6 months after your primary series, the 2 doses of the messenger RNA, your antibodies start to wane. They get lower. So that we saw that the effectiveness dropped to 76% for the Delta variant and only 38% for the Omicron. But if you gave them a booster dose, a third dose, then those vaccines were 94% effective against ER and urgent care visits and 82% effective against the Omicron variant. Next slide. But more important than that, let's look at the hospitalizations. So that after a third dose, you were 94% preventing hospitalizations with our Moderna and Pfizer vaccines. And you were over 90% effective against hospitalizations for the Omicron. So you can see that if they received a total of 3 doses versus 2 doses, extremely effective in protecting against hospitalizations, and also significantly very effective against death. Next slide. So, right now, the CDC is recommending primarily 2 of the 3 vaccines that we had approved of an emergency authorization for COVID-19. And one of the vaccines, Johnson & Johnson, that's the one I took, because I just don't like needles. Sorry, guys. Okay, I'm a one-shot kind of girl. The FDA added a warning for this vaccine, especially for women between the ages of 30 to 49. And what they found out was that a condition called thrombosis with thrombocytopenia, low platelet count. You know, we need those platelets in order to clot our blood in case we cut ourselves or injure ourselves. You know, those platelets are important for clotting our bloods. So it caused thrombosis with thrombocytopenia or blood clots that appeared in 54 cases out of the 17 million people who received a J&J vaccine. Now, that's very low. And at the time, you know, having the vaccine may outweigh the benefits, but we no longer recommend it for the primary vaccination series or boosters unless there are special circumstances. One other warning was noted that they seem to see a higher number of Guillain-Barré syndromes, especially in males. That was also added as a warning for this J&J side effects. And so know and understand about that. Next slide. So I'm going to move forward to talk about why pregnant women should be vaccinated. We've had a total of 125,000 COVID-19 cases, of which 161 of these pregnant mothers have died from 22,000 hospitalizations. We find that pregnant women, if they get COVID-19, they're at a twofold higher risk of being admitted to the critical care unit as opposed to if they were not pregnant. But they have a 70% increased risk of death if they are not vaccinated, but they contract COVID-19 infection. And only 31% of these pregnant women were vaccinated. Of those confirmed cases, 45% were Asians, 25% were Latinx population, and 15.6% were Black, so that you can see that our African American population had the lowest rate of vaccinations while being pregnant. Next slide. This just highlights on the slide the relatively rate of being most likely to be admitted to an intensive care unit. So this highlights the fact that you're 3 times more likely if you have COVID-19 to be admitted to an intensive care unit versus if you were not vaccinated. From complications of COVID-19, you have almost a 3 times rate of being placed on a ventilator. You have a 2.4 times higher rate of being requiring ECMO, and you have a 1.7% higher risk from death as a result of having COVID-19 if you are based on whether if you were pregnant or not. Next slide. So when we looked at a study of 25,896 live-born infants that had a PCR test obtained in a study. 136 were found to have tested positive, and 13% of these live-born infants' parents had testing done during the perinatal period. And almost all were born to mothers with infection close to delivery. And these are the outcomes of infants born to COVID-19 infected mothers. Next slide. So in another study that looked at preterm birth or small for gestational age at birth overall, it determined, in looking at 40,000 pregnant women in a retrospective study, that being vaccinated during pregnancy was not associated with any higher rate of preterm birth or small for gestational age at birth overall. And they stratified that for each trimester of vaccination. And they also stratified looking at the number of vaccine doses received during pregnancy compared with unvaccinated. So the vaccine does not cause you to have a higher association of preterm birth. Next slide. So the benefits of this, of course, vaccination results in robust humoral immunity in pregnant and lactating women. The immunogenicity and reactogenicity is similar to that's observed in non-pregnant women, but the vaccine-induced immune response was significantly greater than a response to natural infection. So you get a better protection during the pregnancy if you were vaccinated and able to transfer this protection to neonates via placenta and breast milk. Next slide. So this just says, this looks at the number of incidents of cases. That top graph shows the number of cases that were occurring if you were fully vaccinated, and a lower rate of cases for COVID-19 if you were unvaccinated. Next slide. This slide does also highlight, just for females, highlighting the fact that females, if you were between the ages of 30 to 39 years of age or 40 to 49 years of age, we did see a higher rate of the thrombocytopenia syndrome associated with the Janssen vaccine doses. Thank you. Next slide. So finally, I just want to say, vaccination is recommended for all women greater than 12 years of age who are pregnant, breastfeeding, or who are trying to get pregnant. ACOG supports this recommendation, and messenger RNA vaccines and adenoviral vector vaccines can be used, but we only primarily are recommending now only messenger RNA vaccines currently with special circumstances. Next slide. So I want to end by saying, what are the recommendations for vaccines? So CDC is only recommending two, Pfizer and Moderna. And you get 2 doses for Pfizer given 3 weeks apart. Moderna, you get 2 doses given 28 days apart. But because we know that this vaccine wanes after a certain period of time, that we are now also recommending for you to be up to date a booster dose. If you're over the age of 18 and older, should get a booster dose of either Pfizer or Moderna 5 months after your last dose in your primary series. So whatever, 2 weeks after your second dose, and 5 months later, know that your antibody response has waned and you should get a booster dose. And don't forget that Moderna is only recommended if you are 18 years and older. And you can mix these doses now. You can mix these vaccines. So for your booster dose, it can be either Pfizer or Moderna. Now, let's say you had gotten Johnson & Johnson like I did. And so you got that one dose. So now for you to get your booster dose, they're recommending that you can get it at least 2 months after that first dose of Johnson & Johnson, as opposed to 5 months with Moderna and Pfizer. But you should use either Pfizer or Moderna as your booster. We are not recommending Johnson & Johnson as your booster because of those side effects I mentioned before. Next slide. I think my last 2 slides to go here. So if you were moderately or severely immunocompromised, let's say you're on active treatment for cancer, leukemia, or of the blood, or tumors, or you're an organ transplant, you're taking medicines to suppress the immune system, or you received a stem cell transplant within the last 2 years and you're taking medicines to suppress the immune systems. And there's some conditions out there that you're born with a severe immunodeficiency called the DeGeorge syndrome or Wiskott-Aldrich syndrome, or you may have advanced or untreated HIV infections. Your immune count is less than 200 cells, CD4 counts. Are you on a treatment with high-dose corticosteroids? You're greater than 20 milligrams per day. And any other drugs like tumor necrosis drugs, alkylating drugs, anti-metabolite kind of drugs that suppresses your immune response would mean you're moderately or severely immunocompromised. In these patients, you should talk about whether an additional primary shot is appropriate for them. Next slide. So if you're immunocompromised, so we're saying that you need a 3rd dose if you're immunocompromised. And then after you take your primary 2 shots, 28 days later, 1 month later, after your 2nd shot for Pfizer, 1 month later, after your shot for Moderna, you are adding an additional 3rd primary shot. So for the immunocompromised, because you can't mount your antibody response like a person who has an normal immune system, you require 3 shots as opposed to the 2 shots initially for your vaccine primary series. Next slide. So for immunocompromised, don't forget, you're going to get your 2 doses shots, whether you're Pfizer or Moderna. You get a 3rd primary shot 1 month later for either of those vaccines. And then you get that 4th shot, which is the booster shot, 4 shots. And that is given 5 months later after your last 3rd additional shot for Pfizer and Moderna. Okay. Now, if you had received Johnson & Johnson initially, then you don't get an additional primary shot, but you do get a booster shot 2 months after that 1st shot. Next slide. So, ladies, I'm going to end by saying, how do you protect yourself? You need to get vaccinated if you have not. Try to stay at home as much as possible. This epidemic's not over yet. I just lost one of my dear critical employees, went to her funeral 2 weeks ago. So don't believe this. It's trending downward, but we still got an immense large number of cases. You need to take this seriously. We need better protection for our masks. You need to wear a KN95 or N95 mask and social distance if you have to be outside. Make sure you wash your hands frequently, carry those hand sanitizers when you're not at home, and try to have all the eligible individuals that are residing in your home vaccinated if you can. Or if you're having frequent visitors or relatives, try to encourage them to be vaccinated. Avoid any large gatherings at this particular time, and learn how to disinfect everything now. You know, those refrigerator handles, computer keyboards, cabinet handles. Take care of yourself and don't forget to get your flu shot, okay? If you didn't get your flu shot, that's important. And I believe that was my last slide.
It was. It was. So thank you so much for that presentation, Dr. Caine. I just want to say there was a question. I think you answered it. Cynthia was asking, what is the estimated percentage of African Americans vaccinated in the U.S.? And I think you had a slide that showed it's about
55%.
55%.
But you know what they said, we had to get to that herd immunity.
Right.
And that herd immunity, originally we said, wow, we only needed to be 70 to 80% of the United States vaccinated. Unfortunately, because we took too long to get to that level, now you have to at least have 90% of the community vaccinated. And I think this virus has become endemic now. It's going to be just like the flu. We'll probably have to get a annual vaccine every year related to this. But folks, I want us to be able to get out there and not have to wear that mask. So you got to help us out here, okay? Protect your loved ones, okay? Protect yourself. Read about the science. And try to do whatever you can in order to help to make our community safe.
I want to add one thing, and I think you did a great job in terms of talking about people that are immunocompromised, because that is a big kind of area of people that have been having the most detrimental effects from COVID-19. The one thing is, even if you are healthy, you yourself are healthy, with Omicron variant, you can be contagious but not symptomatic.
You know, Ellis, I'm so glad you brought this up.
And you don't know, somebody doesn't wear a sign on their forehead that says immunocompromised. So you could be passing that virus on. So you might recover fine, but that person that's immunocompromised that doesn't have that sign on their forehead, you might pass it on to them, and they could become severely ill and or die as a result of becoming infected. And so that's why we're asking you to get vaccinated, not because you're not healthy, but because you may infect someone that isn't as healthy as you are.
And listen, we have seen that there's a higher rate of people infected with the Omicron variant, and they have no symptoms, as many as maybe as 40%. So you'll be walking around just talking normally like I am, putting respiratory droplets in the air, and those droplets can remain in the air for a number of hours. And I can leave, and somebody can come in that space and inhale those respiratory droplets and infect somebody else. So you know that our children, they need protection. Their immune system is not as strong, under the age of 6 months, unless they're getting maternal antibodies from their mothers. But we have the 0 to 5 year olds, or 6 months to 5 year olds. We're still waiting to hear whether FDA is going to approve this new vaccine by Pfizer for that age group. Right. But until that time, we have to have protection.
So talk to me about the distance, right? So when we say stay socially distanced, I know we have said initially it was 6 feet. Is it still 6 feet? Or does it grow, like if you're in a gym and you're working out and you're exerting yourself, should that distance be even?
I don't want the gym folks to get me, hit on me, but I think you got to be very careful about going into a gym or fitness place right now. And I think based on your physical activity and exertion, 6 feet might not be sufficient.
Right.
Some people said even 8 to 10 feet while working out in a gym. And you definitely need to wear a mask if you can work out with a mask, because you have to be very careful. But because of that physical exertion, you may be putting more your mouth is open because, maybe you might be a little bit out of shape. And so that mouth may be open and you may be breathing heavy, and, you might be putting out a few little bit more respiratory droplets. So, hey, think about yoga or some of those other exercises. But you really have to be careful about that.
What do you think is causing the hesitation? Because as we learned last night, children receive up to 14 vaccines by the age of 4. So vaccines have become a part of our normal lives. Why do you think there has been such pushback and such scrutiny about this particular vaccine over the 14 or 15 or 16 others that are available?
I think there are two or three major things. I think one, we didn't do a good enough job in our communications about the vaccine. So coming out of the gate, we didn't explain stuff as carefully and as nice as we needed to. First thing I heard was, oh, this vaccine was produced too quickly. Well, we've been working on this particular vaccine for at least 8 to 10 years, but we didn't explain that. Right. Where we've looked at it for other conditions. And so they're just thinking, wow, it's the first time they ever worked on this particular messenger RNA for this vaccine. So that's the first point. The second point has to do with we had to, because of how deadly this outbreak was, we had to, how do I say it, move people to the side a little bit. So, they're like, whether you got heart disease, diabetes, kidney disease, all these new medications go to FDA. And they go to FDA based on first person who gets there. Okay.
Mm-hmm.
But, what we did was, it's just like voting. If you ever voted and you're standing out in long lines, what we did was, because this was so serious, we brought the person from the back of the line and pushed them to the front of the line for FDA to review it. And it might have taken a year or two if we did the regular process. We didn't have that luxury because too many people are dying. So we didn't take any shortcuts in the quality of the work we did, but we also took shortcuts in the sense that, hey, the pharmaceutical company said, we're going to start producing this vaccine now. We think in our preliminary research studies, our pilot studies, that we think we've got a winner. We're going to go in and just produce this vaccine, which can take up to 6 months. And if it's approved by FDA, we're ready to go. But we don't want to wait until FDA says, hey, it's approved. And now I got to wait 6 more months in order to produce the vaccine.
Right.
So we did some really great steps, but we followed the quality, and we needed to make sure that there's enough people of color part of those clinical trials, okay? Because, white peoples can sometimes have different conditions than African Americans. We may have a higher rate of hypertension. We may have a higher rate of diabetes. So we need to know how this vaccine works with all those conditions.
Right. And I think the one thing I would add is I think sometimes we haven't been privy to this process, right? So all these other vaccines were created in laboratories, and it was only the doctors and the PhDs and for lack of a better term, the science nerds knew what was going on in terms of the vaccine and medicine development. But now this is being played out in the public space, in the public square. And so we're seeing science in real life, and science is always adding and learning new things. And people were taking that as they don't know what they're talking about. And like, no, we've got some new information. And when you get new data, you get a different type of, you have a different response. And so seeing science play out in real time, I think that really.
And I think it's important. No medicine that you're on, whether it's aspirin, whether it's Tylenol, ibuprofen, every drug has side effects.
Yes.
And I can't tell you how many people on so many medicines that they never even bothered to see how long the process took in terms of taking the medicine. So I hope they have some confidence in their healthcare provider. A lot of it is fear,
Yep.
but a lot of misinformation has been put out there purposely to
Yep.
prevent us from getting vaccinated for whatever reason, for those anti-vaccination people. But make it clear, it is us that are dying. Twice the rate in those hospitals. It is us that are the majority in these hospitals that are full. And it is us that are associated with a lot of long-term haul infections. And so
Right.
we're close. But
Just hold on a little bit longer. So Sharon, Sharon had a question. Are breast cancer patients receiving hormone treatment considered immunocompromised?
So no. So they're not they're immunocompromised, but they're not considered immunocompromised to get this fourth dose. So they need to be on like active chemotherapy kind of medication for breast cancer. But once you're on your hormonal treatment after your breast cancer and treatment, you're not considered in that. So this is for the moderately to severely immunocompromised who gets that fourth booster dose.
Right. Okay. So I know you've got other lectures and podcasts and other stuff to do. So we're just so happy that you were able to give us this time today, Dr. Caine. I appreciate it. Guys, please share this with your friends. Tag a friend, share this on your page. Get this information out. Combat the misinformation about the vaccines, about COVID-19. Share this with your friends and family so they can get the true information to get them. What's the new terminology? Not boosted. What is it?
Up to date.
Up to date. We got.
And don't forget, it does not impact or affect fertility related to individuals, even males. So it does not impact it whatsoever. I will make one caution. Sometimes getting the vaccinations may cause some swollen lymph glands, under the armpits. So anybody getting a mammogram may need to get their mammogram before they get vaccinated, or they may have to wait a couple of weeks afterwards, because sometimes you can look like there are changes on your mammogram that may be related to the vaccination. And it's benign and nothing serious from a cancer standpoint.
Yeah, you don't want to scare. That's unnecessary. So thank you. So you've got a compliment.
And get those home kits.
Yes.
They're 85% sensitive. They're not 100%, but they're 85% sensitive. And each household can get 4 kits. So these are home kits, sort of like a pregnancy test. You can get your results in 15 minutes. So, and you can test people who are coming inside your house now. Okay.
And there's two things. There is isolation and there is quarantine. Quarantine is when you think you may have been exposed, but you haven't had a positive test yet. So you should quarantine. Isolation is when you've been exposed and you have tested positive. That's when you should get isolation. So those two different things. I know a lot of times in lay language, we use those terminology interchangeably. They're not. Quarantine is when you've been exposed, but not positive. You haven't tested positive. Isolation, you've been exposed and you've tested positive. So that is a difference. I had to learn that the hard way. But so I got to let you go so you can get to your next appointment.
I appreciate you. Thank you so much.
Thank you so much.
And I just want to thank those wonderful nurses out there. A lot of them they're on the front line, doing the incredible work. Such passionate public servants, and we love you as educators. I know I learned most of my medicine from my nurses. So keep up that phenomenal work. And I love the research that is being done from your academic community. So thanks, Ellis. Maybe next time I see you, you'll graduate to the senior level, huh?
Maybe I'll graduate to the senior level.
I'll worry about you, okay?
Thank you so much. Keep praying for me. Thank you so much.
All right, okay. Bye-bye.